I'm Tim Greene from ONS in Greenwich, sports medicine surgeon. We're going to talk about hamstring injuries today from our young adolescent athletes all the way up to our recreational weekend warriors. And this is a typical scenario for a hamstring injury. You're running, you feel a pop in the back of your thigh, and you turn around and you feel like you've been sniped from the bell tower, like this guy here shot you from the back. And hamstring injuries are most common lower extremity injuries and sports injuries. Almost 30% of the time you're going to see hamstring injuries. And these generally happen in sports with a rapid acceleration. So sports where we're sprinting or jumping or kicking, football, soccer, basketball, those are generally going to produce strains in the muscle, so little muscle injuries. Sports that have more ballistic movement, so more explosive movements under a load, we're going to see more significant injury in those. Those are going to be more tendon injuries, tendons where they attach to the bone. And those are classically more sports like skiing or skating or weightlifting, sometimes even ballistic movements and dancing. So here's the anatomy of the hamstring. So as we go, there are four muscles there. We have the semitendinosus, which is the more superficial tendon. The tendons will go from your sit bone at the pelvis here and then go all the way down towards the knee. They split at the knee and insert on the inside and the outside just below the knee on the shin bone. So our semitendinosus is the more superficial tendon. Underneath that is the semimembranosus. And then we have our biceps femoris tendon, which has long and short heads, which attach to the outer side of the knee. The attachments are a little different. The attachments at the knee split, and each tendon has an attachment on the inside and the outside. At the upper end, more by the tuberosity at the hip, the tendon attachments coalesce. So the biceps tendon and the more superficial semitendinosus come to one common attachment, and then there's a second attachment for the semimembranosus. What's not on here, but what's important, is your sciatic nerve comes just along this area about a centimeter away. So the function of these muscles are to extend the hip here on the right and then to flex the knee. So we can have injuries at 5 different portions of the hamstring. So we can have a tendon injury at the top of the hip where it attaches to the sit bone, a injury between the tendon and the muscle, again, more proximally or up by the buttock, a injury to the muscle itself. And then on the other end, closer to the knee, we can again have an injury between where the muscle and tendon attach together, and then one where the attachment point happens to bone. So the mechanism of the injury. So if we talk about strains is just a nice way to say that you tore a portion of the muscle. And that happens generally by muscle overload. The muscle is stretched beyond the capacity that it can hold the load, and it fails. And a lot of times, these are what's called eccentric loads. And so if you look on the picture on the right, when a hamstring muscle works, it shortens or it contracts, and that's a concentric load. So things like sprinting, where you look at the other leg, as you extend the leg and as the foot hits and as this muscle wants to contract, it's actually being lengthened with a contraction. That's an eccentric load. That's how these injuries happen. And one of the issues is that the hamstring really spans 2 joints. It goes from the hip down past the knee. And this gives a mix of this kind of extreme lengthening with a eccentric load. And that's how these injuries happen. They happen with sprinting. And again, with this combination of lengthening and load. The injuries that you'll see, they come a lot of times at the muscle tendon junction here, where that's the highest load. That's what's most commonly injured. And then again, what's a little less common is into the muscle belly itself. So ruptures, where the actual tendon ruptures from the bone, they're a little more rare. They're a little less common, but they happen in scenarios where the hip is flexed and the knee's extended, and then there's a ballistic or very rapid load. And so classically, it's skiing. So you're sitting in the water, you get pulled over, and your hip flexes, the knee extends, and the tendon pops. And that can happen in areas where there have been, inflammation, the tendon, chronic inflammation, and partial tearing. So risk factors for hamstring injuries: tightness, which is a controversial thing, but as we know that a muscle that is not as pliable really can't take as much load. So we'll see this in kids. As kids grow, the bone outpaces the muscle tendon, and that muscle becomes tight. We can see weakness and fatigue, where the quadriceps and hamstrings really fatigue one quicker than the other. The hamstring may fatigue faster, the quadriceps pulls, and it pulls it out of balance and again creates that eccentric load. Poor conditioning, that goes along with fatigue, and that's why we see these injuries really in a preseason sort of mode. And again, the less pliable, the less endurance that the muscle has, the more quickly it's going to fatigue. And then what's a really important one is prior injury. We're going to get into this in the talk of the treatment, but that's the most significant risk factor for hamstring tears, that we've had an injury. It's scarred. A lot of times as we talk about the recovery, people don't seek treatment. They will rest and let this scar, and it over tightens, and then we have another injury. And that re-injury rate is 2 to 6 times increase when there's been a prior injury. So the symptoms we'll see, and a lot of times this is sudden, as we talk about. You feel like you got shot from the bell tower, a sudden sharp pain in the back of your thigh or buttock. It can be a little less obvious. Sometimes a little bit of tightness or a lack of flexibility can be a small little partial tear. Oftentimes with bigger injuries, we're going to see this big bruising pattern. It will not show up the day of injury. Generally, it shows up a couple days later when this bruising surfaces can go all the way down the leg. We'll see weakness. We'll see difficulty walking, sometimes on crutches, sometimes can't put weight on it. The exam of this, it's really difficult, I think, sometimes to feel a defect when you have these. When the ruptures happen, they happen more up at the buttock, and the glute muscle really covers it, so it's difficult to feel a defect. We'll certainly can see different areas of tenderness, sometimes in the muscle tendon, sometimes where the tendon attaches to bone. What you can see, and very consistent, when there has been a tendon rupture and you lay a patient on their stomach, they oftentimes cannot extend that leg against gravity, and that's a real clue that there's been a significant hamstring injury. So imaging, how do we look at these? So X-ray, you generally won't see much except out of the pediatric population, and that's because their growth plates. We're going to talk about this in more detail, but X-ray can see an avulsion. You can see it down here on the bottom, where a little piece of bone is pulled off with a hamstring. Usually our mainstay of figuring out these injuries, the MRI, that's going to give us really the location of the injury, the degree of the injury, how significant, where's the location, how far away it is. Is it chronic or more acute? And you can see on the MRI image, this side, there's the hamstring that attaches to the bone. If we look on the other side, we can see the bone, there's the arrow, and the star is really at the hamstring tendon. So we see this really large area of displacement. All the white is a big hematoma there. So treatment, how do we treat these? And so for injuries that are more the strains, so they're more tears in the muscle or at the muscle tendon junction, 99% of these injuries are going to be treated conservatively. And that's ice and compression, stretching, it's rest, it's anti-inflammatories. I think with these, the general treatment that I will do is give people a week or two really to let this injury scar up and heal. You know, there's really no surgical indication because you generally can't tear all the way through the muscle. The muscle has such a large volume. But after a week or two, the really important part of this is to get into some therapy. So we're working on releasing that scar and making that muscle more pliable. That's why there's a 2 to 6 times repeat injury risk without treating these, because they really do scar, and we really need to work through some therapy on getting the muscle pliable again, because we can take the load. So this injury timeline, 2 to 4 weeks, that generally going to see the hamstring heal. We need a little therapy after that, sometimes 6 weeks for more severe injuries. We talk about the magic of PRP sometimes, or platelet-rich plasma injections. I think scientifically these things definitely have a place. They work. It's more likely for a chronic injury. If you look at the studies for an acute injury, there's maybe a small earlier return within some elite athletes, but there's really been no good study that shows that this is substantially superior to conventional treatments to get back. What you do see is we haven't really seen any recurrence rate in these studies, and that may be because this eliminates the scar formation and reorganizes the tendon. So again, PRP probably, although you can use it, it's probably not for an acute injury. I think in my hands, it's more in a chronic injury that's just not improving. So when we look at injuries more at the tendon insertion, so more up by the hip, more at the sit bone, these could go either way. Sometimes it depends on the nature of the injury. So if we have a single tendon, so more like that small semimembranosus tear where the other tendons are still attached, and we have less than 2 centimeters of retraction, meaning it's not far from the bone, those injuries can scar in, they can heal. We've seen this borne out in studies over time. So we treat those, again, conservatively, give it rest, give it a couple weeks to scar and settle in. Then we're working therapy, getting the irritation down. Sometimes as these things heal and there's still pain over a longer period of time, in a 2 to 3 month window, I think a cortisone injection is definitely an option to get things to settle, not done on a recurrent basis. And again, that's the role for PRP, particularly if we do a cortisone and the irritation is still there and we need to get past this. So that injury timeline, we think about 6 to 12 weeks. We have to get everything healed. We got to get the muscle function again and then loosened again. Now, these injuries are the ones sometimes that do need operative treatment, and particularly if we're having a rupture and it's ruptured all 3 of the tendons, or it's ruptured the conjoint tendon, so where we have 2 of those tendons meeting and attaching to the bone. And if that rupture happens, we get significant displacement, so more than 2 centimeters. That's oftentimes one where that injury will continue to produce a long-term issue with weakness and sometimes pain. So that is an indication for surgical treatment. Also, when we've tried non-operative treatment as it doesn't work, there's significant pain. We may have tried injection for something that may be a shorter displacement and it's just not getting better. Then, as we talked about in the anatomy, that sciatic nerve is a centimeter away from the hamstring. Sometimes we can see these tears, they tear off, they pull down, they scar into the sciatic nerve. And so when that hamstring is pulling, it's pulling on the nerve, we get sciatic symptoms. So in these cases, we'd go in for a repair. We're going to use 3 to 5 suture anchors on that sit bone. And if you look in studies, around about 4 suture anchors mimics the native strength of the hamstring. So it's very strong in there. We think about this being a 6-month recovery in general. But about 4 weeks on crutches and a brace. This has a very high success rate, 95% good and excellent results with a 60 to 90% return of strength. Our issue would come in these chronic tears where you have an injury and it's more than 6 weeks out. Those results really do lessen over time, even though they can be good. So it's better to treat these earlier and figure these out. So as we kind of move down the more distal injuries, more towards the knee, again, that tendon as it attaches to the knee or at that muscle tendon junction. And again, these generally 99% of the time are going to be treated non-operatively. There are some rare exceptions to this. So when the semitendinosus itself, so that more superficial tendon that attaches to the knee, when it tears and retracts, sometimes it can scar in an abnormal position, or when the muscle tendon unit tears and retracts distally, that can produce some untypical scarring and pain that can't get better. I'm going to show you an example of this out of these injuries. And so this is a 17-year-old high-level track athlete who had a distal rupture of his muscle tendon junction. And I'm going to play the video, and what you're going to see is when he contracts this, every time you see this big ball come out. So this has been a muscle tendon injury right distally, and as he's using it, it's contracting, it's scarred abnormally, pulling down. He gets pulling every time, and he really can't get past this injury back to running. So, the treatment is this. They actually make a couple little small incisions. We take out that portion of the tendon. This is what we do for ACL injuries. We harvest this tendon and remake an ACL graft. So we know that this actually, without this tendon, the leg functions well. Strength comes back. We know this from ACL studies. People can't tell it, and you get rid of that scarring in a pretty minimally invasive surgery. So this is muscle tendon junction. You can do this, or distal hamstring that won't get better, and the actual tendon avulses. You can take it out, much like you do to harvest for an ACL reconstruction. The harder group to treat is when people have an ACL or have a proximal hamstring rupture and they don't recognize it. They rest, they know they have it, and over a 6-month or 1 year period, they start to see, well, this is not going well, it's weak, and then you come and you see that they've got a tendon injury. It's very retracted and now it's scarred there. So now you can't get it back to the bone. So there are some salvage procedures here for reconstructions. So you can see the tear on the left, which is pulled down. So what we oftentimes do is use a cadaver tendon. This is an Achilles. This is a piece of bone. So we kind of whittle off a little piece of bone and attach it into the native sit bone here, and then use this to bridge the gap and sew it into the tendon. So you can kind of see in surgery, this is that tendon going down into the bone, attached to the bone. We can see the other end of the tear, and then we merge these together, and that works very well. It's a long recovery. It can take 1 to 2 years to kind of get that to fire normally. So then we get to our adolescent group, and children aren't many adults. They're their own entity, and it really comes from the growth plate. So this generally what we'll see, again, can be muscle tendon injury, but it tends to be more about the growth plates here. And these become injuries through growth spurts. We see kids, they grow, that bone outpaces the muscle tendon, it pulls harder and create muscle strain, or sometimes these avulsion injuries. And so this can happen at any time, peak incidence between 14 and 25 years of age, and about half of these are going to come around the pelvis. You can see them at other points of the body, but come around the pelvis, and we can see this little plate on the X-ray and the CAT scan is where the hamstring is attached to it, and it's pulled itself away. And much like the tendon injury, it's the same sort of indication for surgery. If it's less than 2 centimeters, that can heal with a bone interval back in and be strongly healed. If it's more than 2 centimeters, generally it's not going to heal. We can't bridge that gap with bone, and that generally needs to be fixed. And we can kind of see on the bottom, screws can strongly fix this in. This heals very well over time. The problems come when they're long-term injuries and we don't recognize them. A lot of times this bone can really overgrow and it's very difficult to fix in time. And again, this is a 4 to 6 week on crutches. It heals very well, a 3-month recovery, and generally they do very well. So we've covered it all from adolescent hamstring injuries to adults. Thank you.